Now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and thank you for joining. We will get started shortly. Good afternoon to everyone who's joining the webinar. We have other attendees who are continuing to sign on, so we're going to give everybody a few more minutes before we start today's webinar. Good afternoon, everyone. It's just now 1 o'clock, but there still are some folks joining, so we'll just give it another minute or two before we start today's webinar. All right, welcome to today's webinar, Getting Ahead of Lead. Can predictive modeling help prevent childhood lead exposure? My name is Amanda Reddy, and I am the Executive Director of the National Center for Healthy Housing. And it is my sincere pleasure to be moderating today's webinar. And we're really excited to be partnering with the Chicago Department of Public Health to bring you this compelling story of putting data into action to prevent lead exposure. Before we get started, though, I'd like to review a few logistical notes with you. Just bear with us for a minute. We're having trouble advancing our slides. There we go. First, today's presentation is going to be recorded. The recording and slides will be made available online at NCHH's website at www.nchh.org within a week of today's presentation. We'll drop a link into the comments section shortly of the exact page where you can find that presentation within the next week. Also, to help minimize background noise, all attendees are on mute in a listen-only mode, but that doesn't mean that we don't want to hear from you. We definitely encourage you to ask questions at any time during the presentation by entering them into the questions box that is probably located on the right side of your screen in that control panel. We will try our best to answer all of your questions before we conclude today's sessions, but if we don't get to them, we will do our best to work with today's panelists to get you the information you've requested after today's webinar. So without further ado, let's go ahead and get started. Some of you may have joined today's webinar because you're a data junkie who just saw the words predictive modeling and just had to know more. And others may be joining because you're trying to shift lead poisoning prevention efforts in your community towards a focus on primary prevention and away from secondary prevention. But I'm guessing most, if not all of us, joined at least in part because we really care about protecting kids. And the truth is, lead poisoning is preventable. We know how to fix it, we know how to prevent it, and doing so is not only the right thing that can help hundreds of thousands of kids have better academic, social, and other outcomes, but it also makes good economic sense. It saves money. There are 2 resources listed here on your screen, the 10 Policies to Prevent and Respond to Childhood Lead Exposure report, and a new tool that came out of that work called as valueofleadprevention.org. And I urge you to check them out if you haven't seen them before. These are 2 resources that really help you to make that case about how lead poisoning prevention makes sense. But of course, prevention only makes sense if we know how to target or invest our resources to maximize our chances at prevention, to be able to find those kids before they are exposed. And today's panelists are going to share a story about one way that the City of Chicago has been tackling that question. So today we're going to hear from Jana Karens and Raed Mansour from the City of Chicago's Department of Public Health. Jana Karens is the Medical Director for Environmental Health at the Chicago Department of Public Health. Prior to that role, she was with CDC as an Epidemic Intelligence Service Officer assigned to Chicago Department of Health Public Health Communicable Disease Program. She's a veterinarian and epidemiologist, and she earned her veterinary medical doctor degree from the University of Pennsylvania School of Veterinary Medicine and her Master of Public Health from the University of Illinois at Chicago. Raed Mansour is the director of the first Office of Innovation at the Chicago Department of Public Health, where he uses a health equity lens to be a catalyst for building a culture of innovation and collaboratively create transformational improvements in public health. He has a Bachelor of Science from Purdue University in Neurobiology and Animal Physiology, a Master of Science in Health Communication from Boston University, and a Certificate in Predictive Analytics from DePaul University. We'll also be hearing from their colleague today, Raed Ghani, who is a professor in the Machine Learning Department in the School of Computer Science and the Heinz College of Information Systems and Public Policy at Carnegie Mellon University. Raed is interested in developing and using computational and data analysis and machine learning methods for solving high-impact social good and public policy problems in a fair and equitable way in areas such as criminal justice, education, healthcare, energy, transportation, economic development, workforce development, and public safety. Prior to his current position at Carnegie Mellon, he was the founder and director of the Center for Data Science and Public Policy Research, an associate professor in the Department of Computer Science, and a senior fellow at the Harris School of Public Policy at the University of Chicago. And prior to that, he has a long and storied career here. He did a variety of other things, including serving as chief scientist at Obama for America's 2012 campaign, focusing on analytics, technology, and data. So this panelist, this set of panelists is going to bring just a wealth of expertise and a really inspiring story to you today. And with that, I will turn it over to Jana.
Hello, everyone. Thank you so much for joining. All right. So I'm just going to start out with a little bit of background. So in Chicago, almost 90% of our housing stock was built prior to 1978 when lead paint was banned. And most of the risk for kids, as most of you probably know, in terms of lead poisoning begins after about 12 months of age, when kids are crawling, walking, and more curious about their surroundings. At this point, they're also exhibiting a lot of hand-to-mouth behavior. This graph shows the percentage of children under the age of 6 in Chicago with elevated blood lead levels. As you can see, in Chicago, like in most of the country, blood lead levels have markedly decreased over time. In the late 1990s, 1 in 4 Chicago children tested had a blood lead level of 10 micrograms per deciliter or higher, while today that number is about 1 in 100. And just a note that this graph shows an elevated blood lead level as 10 micrograms per deciliter, because back in 2014, when we were first working on the predictive model, that was the action level in Illinois. Since then, like much of the nation, we've moved to 5 micrograms per deciliter. So despite this dramatic decrease in the number of children with elevated blood lead levels, there are still great disparities in Chicago. And this map shows that overall 3.5% of children have blood lead levels over 5 in Chicago, at least as of 2014, with the neighborhoods in red having the highest rates of children with elevated blood lead levels. This is coupled with the Child Opportunity Index, which is a composite measure of educational, health and environmental, and economic variables, which are shown by the hatched areas. It's no surprise to those of us in public health that the neighborhoods most affected by lead are those same neighborhoods that are low in economic empowerment, have low childhood opportunity indices, and whose residents face a disproportionate number of health issues. So our plan is to focus our limited resources in these neighborhoods and move that number down even further. So our current model is pretty reactive. Every child with an elevated blood lead level is reported to us as the health department, and then that triggers us to send out our risk assessors to inspect a property and ultimately leads to lead mitigation. But with the model, the goal is to try to predict where kids that are at risk of exposure to lead paint live and to mitigate the hazard before they develop lead poisoning.
Hi, this is Mansour. In 2014, I met Raed Ghani, and we pitched some ideas around whether building a lead predictive model can work. As you can see with this slide, we collect a lot of data across various sources within antiquated and siloed IT infrastructures with the governance to match. The proof of concept was built outside of the city by Raed Ghani's Data Science for Social Good and his fellows. But we still had a lot to do before we can place it into practice. As you can see, that's a lot of data to bring together, and how would it operate within the city? Implementation was one part. We still needed to validate the model, move it into the city, align it with the lead program, and all the while following a myriad of local, state, and federal regulations and maintaining existing practice, and we'll get into that shortly. In 2016, we were awarded a grant from RWJF to validate and implement the lead model, but we added an upstream intervention. We had originally planned for this to be used in the field by the inspectors using a tablet, and we didn't have that process, nor did we have the tablets. So we thought, what if we can work with physicians using an EHR to access our lead predictive model through Alliance Chicago's 4 federally qualified health centers through an API. And Raed will go deeper into the model next and how we worked on it.
Thanks, Raed. Yeah, so as both Jenna and Raed said, like the initial motivation for this was really the health department was taking a reactive approach to dealing with lead poisoning, and that was because of resource constraints. But ideally, we would fix every home in the city, but as Jana said, in a city like Chicago, where a very large percentage of homes were built before 1978, fixing every home wasn't feasible. And so the idea was, how do we prioritize homes that are likely to have adverse effects on kids because of that exposure? So it was both about the kid that's living there, as well as the home that and the combination of the two is what leads to a kid getting exposed and getting high levels of blood lead level. And again, as Raed said, that the predictive model was sort of a first piece, which is what we started to think about, whether it's even feasible to identify homes that we could intervene on. And once it was feasible, building that system and then going deeper into how do we turn it from a prototype to an actual system, how do we validate it to show that it's actually having the impact we want it to have, and then how do we deploy it and have people use it. So this slide is kind of showing what did we use to initially build that system, and it turns out, pretty much this is all administrative data. This is all data that most jurisdictions, city, county, state already have. And so the two primary sources that came from the health department were every kid that was tested in the state, that the city would get the data from the blood tests. So that was our source for historical data for that. The second one was an elevated blood lead level would trigger a home inspection. The city would try to schedule an inspection and then go and check for lead hazards. And that again would administer data that was stored. So that became our primary data, is all the kids that have been tested for lead, whether it was elevated or not, and then second is all the home inspections that happened as a result of that. We then combined that with publicly available data that was available from different sources, whether it's census data to tell us a little bit more about kind of the social determinants around it, whether it was county assessor to figure out when this home was rehabbed, how big this home was, whether it was sort of different types of building permits that were taken out, again for renovations, and then the building footprint, sort of an interesting interesting data source, and it's only interesting in the sense of, a lot of the times when what happens is that buildings happen to be, you have two different addresses at the street corner. One is the building on one side of it, the other one is connected. They're the same building, but they have two different addresses, and you don't want to treat them as two different buildings. And so, looking at the building footprint, we could then combine those into the same building because they share the same structure, the same permits and everything else. So the idea was, how do we take all of this information that we know about kids and homes where they live in, and turn it into different types of predictors to put it into a predictive model that would then generate a risk score for kids that are not yet exposed to that. So kids that are under 6 months old, and if we can then generate an accurate risk score for them, which tells us their future likelihood of getting high levels of lead in that home, then we could start doing preventative work as opposed to the reactive approach from before. I think Ryan's going to go into now how we use this predictive model and the risk scores to then intervene on these kids.
Thanks, Raid. So you see down there in the lower right-hand side, 4 things that we use this model for. And Raid will talk more about the validation, but I'm going to speak about WIC, which stands for Women, Infant, Children program. And we decided to, before bringing the model in, since we had this list, we wanted to see if we can test whether mailing a reminder to children and pregnant women most at risk within the WIC program is effective in getting people to schedule an appointment. We didn't have a lot of capacity to do a lot of preventive inspections. So we said, what if we can work with community-based organizations and see if they can perform the visual inspection? So one of the first uses of this model was to send this behavioral nudge developed with our partners at Ideas 42. And as you can see, some of the things that they helped us with is not to write a government type letter, to see if we can decrease the friction and increase requests for lead inspections. While the lead writing response increased the lead inspection requests, the total number of responses was still at 2%, which is typical for direct marketing. And we knew we weren't getting as large of an impact we were looking for. And Raid will talk more about validating the model now.
Yeah, so one of the things, if you're kind of coming in from if you're a data nerd and kind of coming in from the data side, one of the things that's sort of a lot of these buzzwords, machine learning, data science, big data, AI, a lot of these things are sort of, they're new types of methods, but they still require the same types of validation methodologies that any other evidence-based system requires, right? So anything, if you're coming from the public health side, the validation is, these methods still need to be validated in exactly the same way. And so what we had to do was, when we built the system first, we had 15 years of data around lead exposure, and so it's through blood tests and through home inspections. What we could do is use that data to validate historically whether our model, our approach would have been effective. And the way we did that was first, let's say we have data from 2005 to 2019. Right? What we would do is take the first 5 years of data and pretend that we're living in 2010. We would only show our model data up to 2010 and hide the future. We would build our model and then predict which kids are going to get lead poisoning and in the next year, and then see how correct we were, because we would hide that next year. Then we would move forward by 1 year. So let's pretend now we're living in beginning of 2011. Let's take the last 6 years of data, predict the next year, and see how correct the system is without knowing the future, and keep going, right? What that allowed us to do is, of all the different types of models we could build, and we built thousands of different types of models, we could see which types consistently were accurate at predicting which kids were going to be at risk of lead exposure and lead poisoning, and narrow it down to a smaller number of models that we were confident that we wanted to actually put into an actual trial. This validation of historical data is extremely critical, but not enough to know that this will continue to work in the future. And so that was our starting point. And that allowed us to sort of pick a specific type of machine learning model that was effective historically over many years. What we then next was run a trial, a randomized trial, where we took the predictions that were made by this model for the future, and then gave that list to inspectors at Chicago Department of Public Health. And then those inspectors went out and first, as Ryan was saying, first we would send out letters and make phone calls to get an appointment. And then once the appointment was there for an inspection, they would go and do the inspection, and then we would get the results for the inspection. And the idea was that we wanted, so the population we were looking at, which is what Ryan was talking about, is the WIC population. That is already, it's not a random set of people. Those are kids that are higher risk than random people. So what we wanted to see was, if we just chose homes where WIC kids live, and we would get a pretty good way of targeting our limited resources. The idea here is, again, can we be more efficient and effective at identifying homes with kids at risk of lead poisoning than some other approach? Is a machine learning predictive modeling approach more effective and more equitable at getting us there? And the trial we did was basically comparing different types of approaches to this predictive modeling approach. And we found that the predictive modeling approach resulted in inspecting homes that had lead hazards at a higher rate than other approaches. So that was really what the trial was focused on, is finding, can we identify more homes with lead hazards than other approaches, whether they're random or WIC population or some of the other things that we identified. And so what we're seeing right now is basically the system that we then put into the electronic health record system, right? So the idea was, as Ryan was saying, once you have the capability to accurately predict risk scores for kids getting exposed to lead in the future, that system can be used in a lot of different ways. There are a lot of different interventions you can use now. The obvious one was prioritizing lead hazard inspectors from Chicago Department of Public Health. But there are many others, and so this is one where implemented into a electronic health record system, can you start when you're seeing a pregnant woman and they're coming in for a checkup, going in here and running a risk analysis. What happens is it takes the information for the pregnant woman and where she lives and where the child is going to be born, sends it over to the Chicago Department of Public Health, to the city where the system is running, and then gets you back a score. And that risk score tells the physician what to do next. Is this kid going to be low risk, medium risk, high risk? Should you now, does it alert the health department? Because if it's high risk, is it sort of medium risk? So you give the pregnant woman, the mother, information about what to do, or if it's low risk and you don't need to worry about it. So that's this sort of this piece of, we're talking about sort of the machine learning model as this box, but what that really does is that can you give it information about a child and about an address, and it gives you back a risk score. The rest of it is what's sort of really critical, is how do you turn this into actionable information that results in prevention of these types of things. So what we ended up building was this API. An API is just a fancy word for a computer program that you send some information to, and it gives you back some information. That's basically what it does. So in this case, what this hospital is using, and it's not limited to this clinic. This is a clinic system or hospital system in Chicago called Alliance Chicago. But what they do is they take their electronic health record system, take the information from the expecting mother that's coming in, their address. Mostly it's demographics and address information. Sends it to this API or computer program, and what it returns back is a risk score and instructions on what to do. And that's the slide we were showing about the decision support tool that shows, alert the health department because this is really high risk. And what that allows the health department to do is be much more proactive. Now that they have time to intervene, not in the next week, not 2 weeks, but you have time before the kid is born to figure out, to inspect the place, to figure out how to remediate the problem, and to prevent any lead exposure to the child that's going to be born. So that's the overall system. Is we started with the need to be proactive instead of reactive, instead of going back, instead of getting these tests, triggering the inspection as a result of an elevated blood level. Can we move that process to be earlier? Can we predict which kids are going to be at risk of lead poisoning when they're young, 2, 3, 4, 6 months old, or even earlier when the mother is pregnant? And if we can identify those kids accurately, can we then operationalize it by doing inspections early, incorporating it into electronic health record systems, in hospital systems, connecting it to programs? So one of the things was, these inspections are really expensive, and the city has limited numbers of these lead inspectors who can check for hazards. And so some of the things that we're going to talk about are going to be around how do we make it cheaper? Can we do inspections that are visual inspections without drilling into doors and walls and windows, and see whether that could make it easier and cheaper to scale these types of interventions. Okay, so I think now we're gonna talk. That was the easy part, right? Now we're gonna talk about sort of what kind of challenges did we encounter when doing it, and how different cities might learn from what we have learned over the last 5 to 6, almost 6 years now since we first started talking about this to where we are now.
Yeah, we have a lot of lessons that we've learned, and feel free to jump in, Jana or Raid, on any one of these. So CDPH does have some limited resources for interventions, and Jana can speak more to that with respect to number of inspectors and inspectors that are legally obligated to respond to a lead poisoning, and how do you don't want to shift away resources to address that while you're trying to do prevention. So that was interesting way of how to set the threshold and the capacity and bandwidth of the department's program with the curve of maximum use of this model.
Yeah, I mean, I think that the challenge is, is we've got a limited resource challenge, right? Because that's true for every government agency. I think the tricky thing here was, how do you use the resources to make sure that the outcomes are distributed equitably, right? Because right now, lead poisoning, there's no equity in the type of kids that get these. The other thing is a lot of the funding is for reactive fixes, which I think is a huge challenge. If you go inspect homes that are a result of high blood lead levels, elevated blood lead levels, of course you're going to find high levels of lead hazards in there, because how else did the kid get poisoned, right? So the rate of finding lead hazards in homes where kids were already tested to be high blood lead level is really high. But by fixing those, you're not helping that kid, you're helping future kids. And so the incentive for finding hazards needs to be, prevention is what we need to do, but prevention is going to be less efficient, but much more effective at reducing these problems. So I think that was a big issue of how do the current incentives and fundings are for reactive, incentivized reactive inspections. The health department, rightly so, realizing that's not their goal. Their goal is to help the kids, and prevention is really the right path to doing it. But how do you do that? How do you, in a framework where you're not incentivized financially, with a lot of the grants and money coming for reactive things? That was a big challenge.
Yeah, and even before we even looked at that, the difficulty in accessing certain data sets to validate the model or use other data sets included birth certificates from the state. Here in Chicago, it's a unique where the state has the birth certificate. So one of the things that they told me early on, told Raid and I, that we couldn't use that data in the model. They said that it didn't state we can use this data within our data sharing contract. So that was one obstacle. We looked at immunization records, but they were flat files. There was no automation, but there was not a lot of reliability of whether, where the kids lived in close to real time. So were we going to a home that was where there were adults there and no children or no pregnant women? So we did look at that. We ended up looking at WIC, the Women, Infant, Children Program. It's a USDA program. Unfortunately, the data was in a MS-DOS and still is. It's supposed to be updated. MS-DOS-based system. But as Raid earlier stated, the clientele within this database was ideal, and the data was really good. It served as a proxy for where kids lived or pregnant women lived in close to real time. They update their current address every 4 months, so every quarter. And we were able to use that. But within WIC, there were special rules that we had to comply with in order to use that data. So that's part of the conditions of using WIC data. Inform the state director, inform the patient we're using or the client we're using their data in this manner, and it had to be for health-related improvements in order to use that WIC data. So there was a lot of work in order to get to use this. Also, in this third part, establishing a partner within the healthcare system to pilot it within the electronic health record, the EHR. There was a lot of confusion on whether there should be an agreement or not. And there was a lot of legal advice with not a lot of attorneys. So it created a lot of confusion and hesitancy going forward. We used an attorney, and a lot of other healthcare organizations were not using attorneys, and or the community-based organizations or any other partners, and it became hard to work with some of the hesitancy that was caused by HIPAA concerns. And so that was a a lot of delay from the state, federal government, and the partners. And Raid can talk about some of the difficulty it was, I think, with the validation.
Yeah, I mean, I think that in these types of systems, I think two things happen, right? A lot of times when you're using a lot of these overhyped technologies, there is both the skepticism of whether they're appropriate to use. At the same time, there is a lot of fascination with, we just want to use it. And one of the things we were sort of trying to balance was, how do we remain enthusiastic about trying these things out while making sure that they're validated in a way that's robust and evidence-based before we deploy. And so a lot of the challenges were, when we're starting to build them, we showed that, hey, it looks like that there's a lot of potential in this. The temptation was just to implement and deploy it. And we were pushing back, saying, no, we need to validate it first in order to make sure that it does what we think it does. At the same time, we wanted to make sure that we were not, we were trialing it in a way that where people were completely on board and making sure that they were being effective at running the trial. Right? So a lot of the challenges that we're facing were about, how do we set up this trial that's as close to implementing it, but doing it on a limited basis and making sure. So for example, one of the things that we were doing here was making sure that when these predictions are made, they're basically treated like actual blood tests that are coming up as elevated levels of blood, because it's the same thing. You know, it's slightly less accurate, but if the parents are not treating them as, you know, what's really bad about elevated levels of blood, lead levels, is that you don't get any visible effects of it. And so when you get a positive blood test and you're told that your kid has this problem, you freak out, rightly so, and then you're letting you're going to let the lead inspectors in and check for lead hazards. But when a computer says that you're predicted to have high levels of lead in the future, you may not respond the same way. And the people telling you that might not convince you the same way. They might not be as persuasive as it would be if they knew that you definitely had that. And I think the question is, how do you run this type of trial? How do you validate these types of things while making sure that you're doing it in a way that's ethical, you're doing it in a way that's effective for the kids you're trying to help. So we kind of had a lot of challenges around making sure the trial, we had enough inspections set up, and the inspections were being set up by making phone calls, and the people making the phone calls had different levels of persuasiveness in getting the parents to actually schedule an inspection or trying to get inside their house to make sure that we do that. And I think that's something that we're going to have to figure out as a community as we move in general in public health from reactive to proactive. Today, because the reactive approach, we know something bad has happened. It's easier to take that action. It's easier to convince people to take action, but that reactive approach is mostly useless. The proactive approach is a little bit more tentative. You're not, this kid may not get lead poisoning, and so you're not going to be as persuasive, but it's much more effective. It actually prevents this. And I think in general, in a lot of these public health contexts where we're moving from that, we need to figure out how we train, educate, and inform the different people in this whole process. From the inspectors to the people who are scheduling these inspections, to the parents, the community that's being affected. How do we get them involved? How do we make sure that we can be inclusive in explaining, describing both what we're doing, the impact, and the benefits of this approach. But we spend a lot of time kind of trying to understand those things.
Yeah, and some other
the community partner piece, I think, right, would be good to talk about here, right?
Yeah, we work with CBOs and physicians, but at first, this was before Flint or lead wasn't on anyone's radar 4 or 5 years ago. So it was hard to discuss this with folks to partner with us on this. That was one difficulty we encountered, especially 6 years ago when not a lot of physicians were doing the required screening up until it was required at 5 to enter school. So that was one issue. Abiding by clinical decision support, something we had to learn. We're not, Raid and I aren't pediatricians, and we're not electronic health record experts. But luckily, we had a commissioner that was a pediatrician, but also Alliance Chicago's chief researcher was a pediatrician. She discussed the 5 rights of clinical decision support, the right information to the right person in the right format through the right channel at the right time. So one of the things that was taking very long was the minute you hit the button, the physician hits the button on the EHR, the electronic health record, to retrieve the risk score took over a minute. And she told us that no doctor is going to wait 1 minute for things, or longer than 1 minute for things to come over. So right now, I think, it's 3 seconds, I think, the back and forth time. So some great coding going on there. Also developing standards. At first, we were designing it for centricity, but that would lock us in to using centricity and only for Alliance. So that means we either just build it for one system, or we have to build APIs for 10 different EHR systems if we ever wanted to expand this. So we decided on just a standard call. And if you remember a few slides back, you saw those were pretty standard in all EHRs, the name, the address. And this was a hard pill to swallow after trying to speak to healthcare systems. They just couldn't justify the cost, which was not more than probably $10,000 in coding and time to code their back end of their EHR. They couldn't justify the technology costs on prevention. There was no money to be made. And that was some of the focus groups or interviews we were going out on and asking if you can implement this API, the application program interface that Raid discussed, this computer program that allows 2 systems to speak and exchange. That was hard to convince, but FQHC made sense. Now, though, other systems have approached us, and they said they'd be willing to see if they can work on their backend and connect to our API. So things have changed. These were the challenges back then, and now that we've overcome all these, we were able to try the predictive model in other ways, and Jana can discuss this.
Sure. So one of the ways that we're using the predictive model at this point is to really look at using community health workers. And so Raid had mentioned, I think on the last slide about identifying community partners. And so this is kind of one of the examples of that. So we partnered with a health system that has been working with community health workers on several studies and looking at their feasibility, impact, and cost effectiveness for different health interventions. So specifically in this study, and it's going on right now, but one of the things that we're looking at is among these like WIC clientele, are community health workers effective at using the lead prevention models, kind of risk scores to identify those of the WIC clientele that are at the highest risk, and then getting into those homes and actually doing proactive inspections. And The thing that we're excited about here is that it's community health workers, because the health department itself, unfortunately, because of things like limited resources and also, kind of fear of government, is not as effective as community health workers at getting into homes to do these kind of proactive visual inspections. And then these are just some of the challenges that we've overcome. So one of the things that this project really identified was gaps in these old IT infrastructures. And so one of the things that came out of that is that we developed this new, what we call lead inspector application, or LIA. And so that is basically kind of a new surveillance system for the health department. So currently we use what's called HELPS, which is, I think, lower down on the slide, but the Healthy Homes and Lead Poisoning Surveillance System. But we do have kind of a lot of issues with HELPS, and we weren't getting the data that we wanted out of it. So we were able to develop this new lead inspector application that the inspectors can go out and use tablets to do their inspections, and then we can have the data interface and be used for the predictive model. And then also we identified policies that didn't address new methods and data sharing. And so, Rod, maybe you can talk a little bit more about this, but we did have to amend authority in different ordinances in order to include data science and other analytic models, specifically as it dealt with our schools, the public school system here.
Sure. It was such a short, small amendment, but it packed a lot of power for us to not have to hear that we don't have the authority to use data science or other analytic methods or models. I added that last that underlined sentence, but also epidemiological studies as well. So that was missing from the commissioner's powers and duties. So we did that. It took 6 months overcome that, but we also had an innovative agreement, intergovernmental agreement, and this is available online too. Since the lead project helped us to exchange data between schools and the health department using a unique data sharing agreement, threading the needle between FERPA, which is Family Educational Rights and Privacy Act, and HIPAA, the Health Insurance Portability and Accountability Act, for the benefit of a child's health and education, as we all know that are interconnected. Jana, I think I can go over this. The paper is available online too. This was the proof of concept, or the prototype model, that was written after we worked with Raid. That's also available online, and we can definitely share that with you. Also, we won a couple of awards, one on data sharing and also on digital transformation, because of the way we were looking at data differently. This is all available online also. The code is open, it's very transparent, and you can look through how we went through exchanging the data between the FQHC and the health department, plus introduces you to our thinking and logic. You can go through those codes. And I think we leave it to questions now. Thanks.
Yeah, one thing I do want to sort of take 1 minute and just, if you are, for you guys who are listening, if you are in a jurisdiction and you want to do this, I think the way to think about this is so I would sort of Google data science project scoping, and we have sort of methodology for how do you scope and define these types of projects, right? So in this case, what started off as the health department in Chicago being extremely progressive and forward-thinking, saying we need to be preventative as opposed to reactive. Starting from there to what is the goal? Is the goal to reduce lead poisoning, or is the goal to find homes that have lead hazards? Is the goal to identify children who might be exposed to lead? So thinking about kind of very much goal-driven, is the goal just to do it as cheaply as possible, or to care about equity? To then what interventions we have access to, and in this case, you notice that obvious intervention was directing lead hazard inspections with already existing resources to expanding it dramatically to health providers and seeing can we do that early, or partnering with community organizations, community health workers. So starting with the goals, identifying interventions, identifying data sources that exist internally or externally. The inspections and blood tests were internal data, but then combining that with WIC data, census data, county assessor, housing data. And then we got to the analysis and the machine learning and the hype. Those things kind of came after we'd figured out all of these things. And even there, it was, how do we achieve these goals? How do we inform these interventions using this data that we have to achieve the goals that we've set up? And then build the system and validate the system and deploy the system. So that's how I would think, if you want to move forward with something like this, the code is all there. As Rai just mentioned, it's open source. We want people to use it. We're also happy to help you guys use it and modify and adapt it. But I would kind of focus more on the methodology as much of what are your goals, what are the interventions you have, what data do you need to organize and get people to share with you, and then here's the analysis that you need to do to predict risk scores and then inform those interventions and trials and deployment.
Great. Thank you all for a really inspiring and thoughtful presentation. For those of you who are listening, some of you have already submitted questions, and we'll get to those in just a minute. If you have a question that you haven't yet submitted for our consideration, please use the questions box that should be on the right hand of your screen as part of the control panel. You may need to expand different sections of the control panel to find where you can enter your question, but please keep those questions coming. For our panelists, our first question that came in was, why did you look at kids under 3 and not 6 and under?
So 3 months, the reason for the 3-month thing was, if we predicted somebody was going to be high risk of lead poisoning, we wanted to make sure that we had enough time to intervene with them. If we were going, the closer we get to sort of the age where they're going to get lead poisoning, the less time we have to try to get an inspection scheduled, get the inspection conducted, get the remediation to happen before it's too late. So we prioritized kids, but if you are a city, county, state where you think you can move through that process faster, you can do it later. And again, I think as we fix some of these issues, we can start being better at that. But that was the initial thinking, is we want to do the prediction early enough that we had time for getting the whole thing fixed, getting the remediation to happen. And we need the current process needed a few months at a minimum for that to take place.
I think also the reason for the kids under the age of 3 as opposed to 6 is that when we look at our data, the vast majority of children with elevated blood lead levels in Chicago are identified under the age of 3. So I don't know the exact reasoning, but I think it was that encompassed most of the children.
Great, thank you both. We have our second question is another clarifying question, which is, why is the birth certificate important? Does the mother's age determine the likelihood of poisoning, or are you talking about the birth certificate of the kid? So just another clarifying question.
We were looking at where our population we wanted to identify lived at real time or close to real time. So that was our first guess at addresses where these children would have lived, or a pregnant woman, or just gave birth. So it was both, but it also provided, and Raid can talk about it more, it also provided a lot richer data source.
Yeah, I mean, I think basically, ideally, so partially it's how Chicago is set up, right? Chicago as a city doesn't have people information. Basically, Chicago controls assets as a city, but not people. The county has jurisdiction over people. And so ideally we would just know where people live in Chicago, what age, and kind of have a census of the city, but the city doesn't have that. So ideally we would have, this address has this person, and this has a kid that's 2 months old or 6 months old or 3 months old, we didn't have that. And so the birth certificate was a proxy for finding out where young kids are, and allowed us to sort of get to that. And that was the same for the WIC data. If you sort of heard us talk about the WIC data, because we couldn't get birth certificate data from the state, and we used WIC as a proxy for, if they are getting that, then they must have a kid under, and we could get the data about the children. So you might have a different, you might be in a more integrated city and have access to the data through other ways.
Great. We have a couple more questions. I want to make sure we get through as many of these as we can. Next question is, how generalizable is this model to other cities, small towns, rural areas?
So I think there are two pieces to the model. There's the methodology that takes all of this data and predicts a risk score, which is extremely generalizable, and not just to lead, but to other things. The second is the specific combination of things that lead to somebody getting lead poisoning. That's going to vary based on the data you have and the risk factors and the housing. So I would think of this as, I would use the approach and the methodology and the code and everything else. I wouldn't take the specific, so the model is basically, it takes all these predictors that we talked about and weights different things differently and then combines and gives a risk score. I wouldn't reuse that model literally. I would reuse the methodology to rebuild this model with the same type of data and tune it. So the code does, it takes this historical data and combines these predictors to come up with a risk score. So the methodology is reusable and generalizable. The actual model that takes the weightings of the different predictors are not necessarily generalizable to other jurisdictions and other towns.
I think from the public health perspective too, it really depends on resources. So I think as a city, a large city, we're lucky to have probably more resources in the health department than something like a very small jurisdiction. But I think it also really depends on the health department, kind of in terms of what the ability is to follow up on these actual risk scores that come with the model.
Great. The next question is, could you please review the list of 5 rights?
Oh, yes. This comes from I think it's called the American Health Information Management Association. If you look online, they call it the 5 rights of clinical decision support, and it's more detailed in their document, but this is the right information given to the physician or whoever is in the medical practice. So to the right person is number 2. In the right intervention format. There's not a lot of design capability in the EHR. So we had a lot of ideas, and then they said, no, this is, you can choose between, right, was it blue and red for the button? And yes. How long the string can be, what do you want it to say after high risk or low risk? So the right intervention format, as Alliance had told us, they said, just tell the physician or healthcare provider, tell them what you want them to do. So that's, we were hemming and hawing like, oh, maybe you should. They go, no, straight to the point, through the right channel. So we didn't want to interrupt their workflow. They have a certain way of going about the patient visit. And if we started putting bells and whistles right from the get-go, did that interrupt what they intended to do with that patient? So we needed to be in the correct, right workflow for them. So there's just rules on how you go about it. Of course, we were kind of egocentric with how we wanted it. We wanted to alarm bell them and the screen flashing, here you go. But it wasn't conducive to the way they practiced. So they kind of kept us in line into these 5 rights in our design of this clinical decision support. Is that's fair enough?
Yeah, that's great. I'm going to try and squeeze in a few more questions. If I don't get to your question, those of you who are listening, we will share all of these questions with the panelists and see if we can, we'll email folks afterwards with information and resources, because the questions are coming in fast and furious. We knew people would be interested in this topic, and we want to get you connected to the information. But let's see if we can fit in a few more in the last few minutes. The next question is, have you had any experiences with false negatives? For example, someone conducting DIY renovations in a place that had been designated low risk and then poisoning a child. What did your lawyers think about that type of scenario?
Yeah, so I think any system, whether it's human decision-making or computer decision-making, is going to have false positives and false negatives. And false positives in this case are, wasting resources, so not as bad as false negatives that are leaving these kids out as low risk, but as you, and I think that's the reason you want these trials, right? And because you don't want to just go and deploy these things. They're going to have these errors. The question is how much. What error is acceptable, and then what error is better than the error today. So right now, pretty much everything is a false negative, because we only do things reactively, which means we miss everyone. We prevent future kids who are going to live in that house. So today we have a horribly high false negative rate, and what we found was that this is a much lower false negative rate. Now, it's still not zero is what we need to be. But the thing to kind of keep in mind is that I would say to keep two things in mind. One is you want the false negative rate to be lower than what it is today, but you also want the false negative rate to be equitable, right? You don't want to miss 80% of African American kids while you're only missing 5% of white kids, or 60% of kids in rich neighborhoods and 90% of kids in poor neighborhoods are being missed. So you want effectiveness in this overall, which is the false negative rate, but you also want equity in the false negative rate, and you don't want to disproportionately miss people who are already higher at risk. I'll leave the lawyer question to probably Jenna.
Yeah, I'm not sure that I can speak to the lawyer aspect of it, but basically exactly what you just said, right, is that, the false negatives, so the ones that we would be missed are basically all we are dealing with in the reactive method, and so any proactive method would be better than that.
Great, and I know we're just about at time, but let's try and answer one more question here, which is, how do all of you think that federal agencies should leverage your work and scale your model? Or should they, and if so, how?
Well, no one's ever asked us that before, I think, and it's a great question.
Federal agencies doing something?
Yeah, a lot of this is fed back and forth between the states and federal government and the reporting agencies. They do have access to a lot of data. Whether it's feasible for them to build predictive models for every city, state, or region or county, I don't know what that all would entail. Maybe Raid can answer that, but there has to be a better way of automating this back to the cities or the local health departments, making it easier for us to customize what we want and what we want to see. These are designed without us, these databases. They're not referencing other cities, at least I'm not aware of, when they come out with versions. It's only after the fact that they discover the problems that the local health departments are feeling. So there's a lot of friction, I think, to what we want and what they think we should get. So we innovate instead of with them, we innovate in spite of them, and that I don't like that system currently.
Great. Well, thank you very much for that thoughtful answer. We are a few minutes over time, so I want to thank again all of our panelists for the really amazing work that you're doing on the ground and for taking the time to share your story with all of us today. The slides and the recording of today's presentation will be made available online. You'll receive a follow-up email if you registered for this webinar with links to those materials, as well as the other resources that were mentioned during today's presentation, and some answers to some of the questions that we weren't able to get to during the hour we had together today. Thanks everyone for joining, and this concludes today's webinar.